Thank you. So I'll start with my friend and a good colleague, Dimos Andrea from Berlin, on surgery new aspects. Please, Dimos.
Yes, thank you, Andreas, for the presentation. And I hope you are now seeing my screen and my slides.
Yeah.
And let me just start by saying how challenging it is to follow this early morning session from the patient advocacy perspective. I really found everything very moving, and it made, for me, the things that I'm going to discuss in the next couple of minutes seem a bit trivial. And I'd like to thank Uta for organizing this session, putting the patient perspective in the front. And I have to say also that I found, when I started preparing this presentation, I thought to myself, well, the new aspects in the surgical treatment of Ewing sarcoma, well, that's going to be fun. There is really not so much to discuss. And I sort of smiled when I noticed that Uta put a question mark beside the word new aspects, indicating herself that there is really not so much happening in terms of research right now. And, you know, this is sort of a pity, because many studies we are all well acquainted of have shown the importance of local treatment in general and surgery in particular on the prognosis of patients with Ewing sarcoma, but it's amazing how little is happening in terms of research. So one of the studies I personally found nice that were recently published by Uta's team examined the impact of the local treatment recommendations of the CES Interdisciplinary Tumor Board on patient survival. And what this study showed was that in the complex situation of patients with a difficult situation where the treating physicians decided that they need the help from the CES Tumor Board, that in those patients who receive a recommendation and this recommendation was followed, the overall survival was significantly better than the patients who got the recommendation and it was not followed. And what I particularly found nice in this study was that if you see the reasons that the authors analyzed why the recommendations were not followed in some of the patients, you see that only in about a fourth of the patients, it was the expected toxicity of the treatment or the general condition of the patient, the reason why the recommendation was not followed. And the reasons for all other recommendations that were not followed amounted to pretty much more or less, well, we just didn't do it. And for me, this study was a great reminder of the fact that even in the most complex local treatment situations, we seem to have the knowledge of what we need to do, at least at the expert level, in order to get the best possible outcome for our patients. What we seem to do very little in terms of research in order to further this knowledge and to disseminate this knowledge as well. Therefore, I thought to myself, perhaps I could discuss a little bit about new options in reconstruction in Ewing sarcoma patients. And of course, I realize we have a lot of people who are not orthopedic oncologists today, and your eyes are probably already starting to glaze over, and you're thinking to yourselves, oh God, let me get another coffee first. And please bear with me, I will try to keep this interesting for you as well. So one topic that a lot of studies have been published recently on is the reconstruction of distal tibia in patients with malignant bone tumors. And of course, we all know that the distal tibia is a rare site for Ewing sarcoma, but for those patients who do have a tumor located there, it can be very challenging for the treating physician to perform an adequate reconstruction. The usual way to go in the past has been traditionally a biological reconstruction with the fibula graft, which once it has healed, as you can see here or here, offers the great advantage of it's a very durable solution. The problem is that it takes a lot of time to go from here, how it looks directly after surgery, to here. And these are some data that our group from Berlin published a couple of years ago, showing that the majority of the patients develop early complications after such a reconstruction. And also the time until the patients get to full weight bearing can be long or even very, very long. And obviously, we need to keep in mind that we have some patients where this time is perhaps of somewhat of an issue. And these data have also recently been confirmed in a presentation from the Basler group, which has a very extensive experience with biological reconstruction in last week's EMSOS meeting, where again, they showed that they had in their patients a very, very high rate of complications after fibula interpositions, both graft-related with fractures, but also other complications as well, making it challenging to identify the right patients where we need to invest this very long time for their reconstruction to heal. Now, obviously, there are also other solutions. A traditional solution is the Megaprosthetic Replacement, and there we also have some new developments. This is a study published by the Essener group on a novel 3D printed custom-made intercalagry megaprosthesis with a highly cancellous titanium alloy surface. So in this novel implant, the surgeon gets so a 3D reconstruction of the affected limb and decides where they want to do their osteotomy levels. Then the surgeon sends that to the company, which then creates a possible solution with an implant that has the fixation. And once the surgeon has approved of this implant, it goes into production specifically for a specific patient. And this is how such an implant looks like. And you may notice that the surface is very, very rough. This is the highly cancellous surface, which has the goal of allowing a much better soft tissue ingrowth to the implant, and therefore hopefully minimizing the dead spaces that occur after the resection of bone sarcomas, and hopefully minimize the complications that are associated with such dead spaces, as infection being the most important one. This is how it looks after the reconstruction, and I have to say this looks very nice, but the authors themselves said they only have published a very small series of 4 patients with short to mid-term follow-up, and they say that themselves that we need, of course, to wait for long-term results in order to say how these implants fare in the long term. Apart from these novel implants, we also have the traditional solution in the distal tibia of the traditional distal tibia replacements, which we have been using rather infrequently due to their high rate of complications. And I was happy to see that our co-chair, Anna, recently published the experience of their group with these reconstructions. And what they showed was that on the one hand, they do have some experience now with new implant designs, such as this unconstrained implant, which is less bulky at the point of the ankle, allowing for a somewhat better soft tissue coverage on the one hand, but also the possibility of having expandable prosthesis in order to allow the reconstruction of possible limb length discrepancies occurring in young patients after treatment. Now, again, in this series, though, the group of Anna showed that the early complication rate was rather high, with about 20% of the patients. And what I particularly found very nice was the fact that they also evaluated the impact of this reconstruction on the timing of consolidation chemotherapy. And they showed that in about half of the patients, due to the reconstruction that was performed, the timing of adjuvant chemotherapy had to be delayed. Now, I found this very important because we heard yesterday a lot of data on the importance of dose intensification and treatment intensification in Ewing sarcoma and how this is important for patient prognosis. And obviously, complications tend to be of a problem, lead to delays, and these delays lead to less intense treatment. But there are up to now not so many data on the direct impact of these treatment delays on prognosis, which is why we decided to look at the data of the Ewing 99 trial to examine this. And what we did was that we performed a retrospective analysis of the data of about 700 patients with localized Ewing sarcoma who all underwent surgical treatment and try to see what the delays did on their prognosis. So the median interval between the biopsy and the beginning of induction treatment in these patients amounted to 14 days. About 2/3 of the patients had the surgery after exactly 6 cycles of chemotherapy, as was stipulated in the protocol. And in these patients, the median interval between the beginning of chemotherapy and surgery amounted to about 20 weeks, and the interval between surgery and the beginning of adjuvant chemotherapy amounted to 17 days. Now we use ROC curve analysis to calculate the optimal cutoff points for survival analysis, and for the interval biopsy to be the 1 cycle, we found an interval of 22 days, and saw that patients with shorter intervals had a better event-free survival probability, but the differences we saw in overall survival probability were not statistically significant. On the other hand, in terms of the interval between the beginning of chemotherapy and surgery, we saw that patients with shorter intervals did have a significantly higher event-free survival probability, with an effect size of about 15% at 5 years, and a significantly higher overall survival probability, with an effect size of 10% at 5 years, compared to patients with longer intervals. And of course, we ask ourselves, what are the reasons for treatment delays in these patients? So on the one hand, we saw that patients with longer intervals had a significant delay in the treatment between the beginning of the 6th beta cycle and surgery. So that's the point where the patients get referred from the pediatric oncologist or the medical oncologist to the orthopedic surgeons. And we saw that apparently there are several patients who have a lot of delays in this referral, and this leads to delays in the complete neoadjuvant block. And also what we saw was that the probability of treatment delays was much, much higher in patients treated in low volume centers compared to patients treated in high volume centers. And I think this also shows, again, very nicely that aligns the necessity of treating patients with a rare disease such as Ewing sarcoma in high volume experience centers, where every physician knows what needs to be done in order to get the best possible outcome for our patients. Finally, what we also examined was the interval between surgery and the beginning of consolidation treatment, with an optimal cutoff word of value of 3 weeks. We saw that patients with shorter intervals again had a significantly higher event-free survival probability and overall survival probability compared to patients with longer intervals. And again, the effect size was about 10 to 15% at 5 years. And also here we want to see whether we could identify possible reasons, and found that postoperative complications were significantly more common in patients who had treatment delays, suggesting that, as expected, these complications do have an immediate impact on patient treatment and outcome, because they lead to a delay in consolidation chemotherapy. So we also were able to do a multivariate analysis, and found that non-prognostic factors, but also the 2 last intervals, longer intervals between the beginning of chemotherapy and surgery, or between surgery and the timing of adjuvant chemotherapy, were associated with a poor patient outcome. And if we go back now to these distal tibia reconstructions we discussed at the beginning of this talk, we have to ask ourselves sometimes whether these excellent, from a surgical point of view, reconstructions may not be so good for at least some of our patients who cannot possibly afford delays or pauses in their treatment. And this is why I was very happy to see that the group of our other co-chair, Andreas Leitner in Graz, together with their colleagues from Vienna, recently published a comparative study between limb salvage surgery and amputation in patients with untitled sarcomas. And this study again showed very nicely, on the one hand, that the complication rate after limb sparing resection was significantly higher, and that these complications after limb sparing resection almost always need further surgical treatment, while many complications after amputation can be treated conservatively. But they also analyzed a lot of quality of life data, and showed that patients with below-knee amputation had no differences in their quality of patient-reported quality of life values compared to patients undergoing major resections such as the ones we would need for Ewing sarcoma. And this was particularly interesting because many of the patients in this study were elderly, and we know from other studies that elderly patients tend to cope worse after amputation than younger patients do. So coming to the end of this presentation, even the things that I discussed with you right now seem very, very poor, trivial, unimportant compared to the massive and great studies we saw yesterday in basic research and clinical research as well in Ewing sarcoma. And I think we do need to do much, much better in terms of surgical treatment. And that's the reason why I'm particularly happy that the European Ewing Consortium has now established a working group for the surgical treatment of patients, which I have the privilege to chair. My co-chair is Michael Perry from the United Kingdom. And as you can see here, we have an amazing roster of very experienced Ewing sarcoma experts, most of them being orthopedic oncologists, of course, but also pediatric oncologists, medical oncologists. And coming back to what we heard this morning, especially the talk from Ornella, we also have patients and patient advocates in this group who should help us sort of define the questions that we need to be asking in order to generate more new and better data for the surgical treatment of Ewing sarcoma patients. And we hope that we are going to be able to start generating this data in the next time. With that, I would like to thank you for your attention, and I'd be happy to take any questions.
Thank you, Dimo, for this excellent talk. We've got 2 minutes left. There's one question by Martin Benisch. Of 692 patients, only 485 underwent surgery after the chemotherapy. What happened to the other 207 patients?
Yeah, so what we saw by most of these patients was that you have some delays in treatment. The surgeon says, well, I can't operate the patient right at this moment because I saw him too late. And most of these patients got one of the blocks of adjuvant chemotherapy before surgery, so the BI block. And we obviously wanted to exclude these patients from the analysis of that interval because we didn't want to introduce an additional bias. But this was also stipulated in the protocol that it's allowed to give some of the consolidation treatment before surgery if you have problems.
And the next question is on the same topic or on the same paper. Why is the resection status of the surgery and the application of the radiotherapy not included in the multivariate model?
We did several multivariate models in this study, but we need to be a little bit careful with what we did. The resection status and the radiotherapy also are very important, and we also performed subgroup analysis where we focused on the patients that we had wide surgical margins because we didn't want a further bias, but the results were essentially the same. I just showed you, in the interest of time, only one of the analyses that we performed there.
There is a very important comment by Professor Jürgens that it's very important, despite Corona times, we cannot avoid delays in cancer treatment. So I think this is absolutely true, and we have to really focus also on that. The last question is there a collaboration between the surgery working group of EEC and the local therapy working group in the Osteosarcoma Consortium?
Not yet. So the surgery working group of the EEC just got together in July of the last year, and we are still trying to get organized and get sorted out what priorities we are going to have. We have already been encouraged to also work with the hibiscus projects we heard a little bit about yesterday, and we are obviously very, very open to collaborations with further groups. But for me, one of the most important things is that we also get results from this group. I don't want just to have talks. I know this sounds a little bit silly, but I really want this group to promote new research in the surgical treatment of Ewing sarcoma, because that is our most important mandate, and that will be our first priority. Obviously, having said that, further collaborations are always welcome and very important.
Thank you, Dimo. Thank you. So we stay in Germany, but move now to radiation therapy. And please, Beate Timmermann, on radiation therapy, the European strategies.
Yeah, hello. I'm happy to present the European strategy for radiotherapy for Ewing sarcomas, and I thought I should go to some, oh, it's not moving out, to some background, but then also focus on the upcoming Ewing study and talk about some additional projects. So I think we have understood from Dimo, but already from the yesterday's presentation, that cure in Ewing sarcomas can only be achieved by both systemic and local control. So the local therapy modalities are of major importance when talking about Ewing sarcomas. However, it is very difficult to, let's say, compare the local therapy modalities we have, which is surgery and radiation therapy, as the use of those local therapies is very different. So if we look into the cohorts of patients receiving radiotherapy or surgery, or radiotherapy and surgery, those differ widely. So we have differences according to tumor size. So typically larger lesions are going to be irradiated. We have differences for site of tumors. So typically the trunk tumors are more likely to be irradiated. We have difference in ages. So typically young age, we try to spare more from radiotherapy. We look into response and of course on resectability. So therefore it's of course very difficult to compare those two groups. So there are some data telling about who would be irradiated and what site is irradiated. And this is exactly reflecting what I'm saying. So we have very, very typical distributions of local therapies. In extremities, it's more likely to receive surgery, whereas in pelvic tumors, it's more likely to receive radiotherapy, either alone or in combination with the surgery. And in other sites, it's kind of equally distributed to receive either of those three options. So still, when as a radio-oncologist, typically we have to face several challenges coming from the sites of the tumors, which typically mean that the sites or the target volumes are close to very critical structures like CNS or intestine or gonads. And so we have critical sites to be treated, which also carry a risk for adverse events. We have young patients in general in Ewing sarcomas, of course, as compared to other patients we see typically in radiation oncology departments. And we have very high intensities also with regard to local approach, but also coming from the multimodality burden, because all of the patients are typically pre-treated with chemotherapy and may receive chemotherapy during treatment and after treatment. So of course, whatever we do, we have to consider feasibility of our treatment with regard to early and late effects. So therefore, it's of course of tremendous importance to understand the need for doses of radiotherapy, as we know that higher doses typically means higher risk for sequelae. So we try to minimize dose typically as much as possible, but still, of course, having the best chance to achieve cure. So therefore, if we look into doses and studies, for example, so this is a summary of studies we are having on radiotherapy doses, we see a kind of a range for post-operative doses from 45 to 54 gray. And with regard to definite RT doses, so to doses given to those patients not having had a complete tumor resection, then typically we have 54 to 60 gray in the former European Ewing trials. So when we look into publications on postoperative radiotherapy, we in principle see the same. Typically doses were given from 45 to 54. However, typically it's not clearly stated how the risk factors were taken into account in those strategies. And also it was typically not analyzed how the doses were successful when considering risk factors. Local control rates typically were quite nice after surgery plus postoperative radiotherapy, with about 85 to 90% local control rates. So when looking on definite radiotherapy for patients not being resectable, or tumors not being resectable, definite doses of RT were typically higher, with about 54 to 64 gray. But here again, typically risk stratification for different dose levels were not given, and we still have rates of recurrence of 20 to about 40% when looking into those publications. What of course is interesting to look into is if in the particularly the definite radiotherapy group, where we have to treat macroscopic tumor, is higher dose better? So I think this is a really important question for us radiation oncologists, because we need to justify, of course, if we give higher dose, which is potentially, of course, also more toxic. And there was one more recent abstract published by the group from Siddhartha Laska, randomizing 55.8 gray versus 70 gray, and they showed an improved outcome for the higher dose level in those patients and not having been resectable. And I think that's, of course, a very interesting finding. And there were also some other papers suggesting that maybe for some subgroups, dose may be relevant. So when we look into the upcoming Ewing study, we have the kind of typical indications overall to administer radiotherapy. So we have postoperative radiotherapy to be delivered according to margins, but also to site or chemotherapy response. Preoperative radiotherapy typically is not given very often, whereas definite radiotherapy, of course, need to be given when resectability is not likely, and this, of course, need to be discussed in an MDT. And we have some other reasons to administer radiotherapy, like metastasis, but also, for example, in palliation, it may be a very powerful tool. So typically, as in all Ewing studies, or in all Ewing studies, radiotherapy is embedded in a schedule of chemotherapy, surgery, staging information. So it's a truly incorporated piece here. And what is, of course, as a radiation oncologist, really nice that we were able to include a randomized question for radiotherapy in the Ewing study. And the idea was to have a better understanding of the doses needed for various risk groups. So we defined 4 risk groups for the Ewing study: 2 for adjuvant or postoperative radiotherapy, and 2 for definite radiotherapy. And this was depending on surgical margins, or tumor size, or tumor site, or pathologic fracture. So we have 4 dose groups with two respective dose levels, all of them differing for 9 gray. So in the adjuvant low risk group, 45 versus 54 group; in the adjuvant higher risk group, 50.4 versus 59.4. And for the definite group, low risk, 54 versus 63 gray. And in the high risk, very high risk definitive group, we have 59.4 versus 68.4, which is kind of similar to the strategy from Laska et al. I have presented. And of course, we need to look at the results in terms of toxicity, but also in terms of local control. And I hope we can really achieve a better understanding of necessary dose levels for Ewing sarcomas. And we have just received yesterday the approval from the German Radiation Oncology Society on radiation safety, which is a kind of a clear go for our study, and we hope to be able to open it soon. Of course, as the radiotherapy is going to be really demanding, we have agreed with the study that we would work on an addendum of the protocol, giving a better or very close RT guidance, because I feel that what we need to deliver here in that dose escalation groups will be demanding for some organs at risk, and we have to really advise our partners how to do it, and it needs to be done in a standardized way. And this will be also reviewed after radiotherapy. So this is the first Ewing study, which will be accompanied in Europe by a quality assurance program, and will have also a very detailed collection of data of radiotherapy, also taken into account the data sets of the radiotherapy, which from our point of view is really important to understand what was delivered and if this was according to the protocol. And it will also help to go into a pattern of failure analysis, for example, which so far is really difficult because the study do not own enough data on radiotherapy details. So I think this will be a major step forward in order to understand quality and to homogenize therapy approaches over time. As I said, radiotherapy is going to be really demanding. So we, of course, have to point out in the protocol and in the guidance that the newer modalities, modern modalities, are of major importance. And that is in particular intensity modulation. Intensity modulation can be done either by proton therapy or by photon therapy, but it will be important, and it would also enable to do a simultaneous integrated boost, meaning that for different risk areas, we can deliver within one field different dose intensities, and this can be also helpful for sparing. So this is an example of a Ewing tumor where we try to spare the femoral head within the treatment volume. This is what we can only do with intensity modulation, and this I think typically is available either with photons or with protons. And of course, protons have a high impact nowadays, at least in Germany. So I had a look at what we have treated in the last years, and this is about 150 patients already with Ewing sarcoma. So there is an increasing number being referred to specialized centers in order to be able to deliver highly conformal and precise therapies. And if you have a look here at the sites being treated, you see exactly what we said, that typically is really the central site, which is the one being picked for radiotherapy. And of course, here also protons have some advantages. So Dimo already said that local therapy is important. Local therapy board interdisciplinary discussions are important. So we are really happy that since some while we have our local therapy board coming together, discussing cases before treatment, after treatment. I think this is also important to have a growing understanding between surgeons and radiation oncologists about the possibilities they have, the risks they see, to have the best weighting and balancing of local therapy strategies for our patients. So Dimo already pointed out that there's this Ewing Consortium, and I'm also happy to be the chair of the RT group within that EEC consortium. And I think it's really a nice thing because we can connect efforts from the two European study groups, IR Ewing and Inter Ewing 1. We have really a large group of radiation oncologists. Please see at all the names listed here, meeting on a regular basis. And I think I've never discussed with so many radiation oncologists on Ewing sarcomas, and that's of course really thrilling and motivating. And we are also connecting with surgeons and oncologists within our meeting. So we also connect the disciplines among each other very nicely. And I think we will have the chance to bring together our data to improve understanding of radiotherapy, and yeah, we are really looking forward to this initiative. So just shortly, I would also say that in principle, the idea from the Inter Ewing 1 trial is also similar, because they are also looking into doses, and there was a talk already by the Inter Ewing on the Inter-Ewing 1 trial. So here we will have 2 randomizations, one for definitive radiotherapy, 54 versus 64.8. So here it's also a dose escalation question: is more dose better for gross tumor? And the second question is on postoperative radiotherapy, and this question is 45 gray the same effective as 54 gray? So this is in principle a de-escalation a question. And here we have 2 dose levels in the Ewing. We have 4 different dose levels, but I think the underlying question is very similar. And also here there is the quality assurance project. So also here data of treatment planning will be collected, and I think this is really a major step forward in the European Ewing studies, that we have now quality control of radiotherapy. So you have seen this here. So those are the 2 randomized questions within this trial. And obviously we have the same questions to be answered, that we don't know exactly the best dose for the patients. And I think both the quality assurance programs collecting treatment plan data, but also the interaction on the EEC level will allow that we can really better understand if the target volumes we tailor for each patient are appropriate. What is the margin we have to take into account to cover microscopic spread, etc. So all these questions we will only be able when having large data sets of treatment planning and information on failure. And for this, the studies and the cooperation on an international level, I think, will be really extremely valuable. I also would like to highlight, and this I put in particular also for the patients, that they know that we really care about late effects and understanding of consequences of radiation. So there is one major European grant currently open, and this is investigating health effects of radiation, both from diagnostics and from radiotherapy. And we're looking on some domains because you can never investigate everything. So we are looking on neurovasculopathy, endocrinopathy, secondary primary cancer, quality of life, and cardiotoxicity in a data set of about 2,500 children. This is funded by the European Union with about 7 million euro, and we have 24 partners in all over Europe. And we are really looking forward with those initiatives to work on radiation and late effects. And the database is structured in a way that it can connect via REDCap to the American registry for children. So also here is a unique chance that we can connect European data to US data and even have a greater database, of course, over time. So in summary, I think that radiotherapy is truly challenging in Ewing sarcomas. We have to admit as scientists that we have many open questions to be answered. We know that radiotherapy is an important component of the multimodality treatment, and that will remain, of course, also in the upcoming studies. We are going to investigate RT doses in a randomized question within the Ewing study, but also in the Inter-Ewing 1 study. The treatment will be technically demanding, particularly for the dose escalation groups. And so therefore, modern, highly conformal radiation techniques will be crucial for this study. Quality assurance is a very important tool in order to ensure safe administration of treatment, but also to help further research and better understanding. And I'm really happy that I think we have a growing, increasing, very close interdisciplinary collaboration, which is really very important and also very motivating from my point of view. And I'm also sure that the international activities which are ongoing will foster progress of radiation therapy in Ewing sarcomas. Thank you.
Thank you for this excellent talk. I think you have shown very nicely that proton therapy has been a major step forward. Are there any questions? If not, I've got one. What about carbon ion therapy, radiotherapy? Is this also something helpful, or is it overestimated?
Yeah, carbon ion therapy needs special, let's say, approval, particularly for pediatric patients. So this can be only done in a particular study. It was done for osteosarcomas, and it seemed to be effective. However, there's no proof that it is superior to proton therapy. So it's very difficult to tell if there's an additional benefit. It's also given in different fractionations from photons and protons. So therefore, it's difficult to compare. I think the issue is that typically carbon ions are used for gross tumor volume. And in Ewing sarcomas, we also have wide normal tissue areas with microscopic tumor, where we would not want to give carbons, but rather protons or photons with a lower radiobiological aggressiveness. So therefore, it could be considered for a boost, but it's not matter of the new study.
Thank you again. So we stay with radiation therapy, but we move to the States, and it must be quite early there. So thank you for joining so early. And please, Arnold Paulino, again on the American strategies on radiation therapy.
Okay, thank you very much. So I'm going to talk mainly about the North American perspective as far as radiation therapy. So yeah, it's very early here. It's 3:25 a.m. And I think this is the earliest talk I've ever given. So we're gonna review how radiotherapy volumes have evolved over time in North America. We're gonna look at some dose escalation studies in North America for tumors that are greater than 8 centimeters, and also examine the modern radiotherapy technologies that are available. So many of you already know that it has been 100 years since James Ewing had described Ewing sarcoma. And in fact, he was the first man of the year for Time magazine. But one of the most important observations, when he first described this tumor is this is responsive to radium implants. And so radiation can be used as local control as well as surgery for this type of tumor. And radiotherapy can be used as definitive local control, or it can be used in addition to surgery, either preoperative or postoperative. So how do we decide? Well, usually it's a case selection. Surgery more likely to be done in bones that are can easily be removed, and also in younger children. Radiation likely to be used in pelvic and spine lesions or unresectable lesions because of location or tumor size, but also in metastatic disease. So in North America, usually we give 12 weeks of chemotherapy, and then local therapy is delivered. This is a study showing, the impact of local control delay in the overall survival of patients with localized Ewing sarcoma. This is the National Cancer Database. And we have 18 patients with localized Ewing sarcoma. You can see the survival difference between doing local therapy from 6 to 15 weeks from the initiation of chemotherapy versus more than 16 weeks from the initiation of chemotherapy. And actually, when you look at, letter A, which is radiation therapy, B, which is surgery, and C, which is surgery and radiation therapy, it's really the definitive radiation therapy group where you see this difference in overall survival. So again, I'm going to talk about the three teams. The first is reducing target volumes for radiotherapy. So what exactly do we treat when we radiate the patient? Do we treat the entire bone? Do we do a tailored field, treat the initial tumor in the bone and soft tissue? or do we treat a post-induction chemotherapy volume? Well, this was answered in the pediatric oncology group 8346, where there was a randomization of whole bone radiation therapy versus tailored field radiation therapy. And basically in that particular study, there was no difference in local control, whether you do entire bone or just involve field. And the margins that were used for the involved field was 2 centimeters. But what's more important is the quality of radiation that was delivered. If the case was delivered appropriately according to the radiotherapy guidelines of the protocol, the 5-year local control was 80%. But if there was a minor deviation or a major deviation, the local control rates were much lower. In the 1990s, then the initial radiation field was to treat the initial bone and soft tissue tumor with a 2 to 3 centimeter margin to a dose of 45 gray, and then a smaller volume, which is the initial bone and the post-induction chemotherapy, plus a 1.5 to 2 centimeter margin for another 10.8 gray. And the total dose to the tumor was 55.8 gray. So this shows you the local control by modality in 3 successive trials in North America, Intergroup 91, 154, and AEW 0031. And what you see here, in a little bit over half of the patients, definitive surgery was utilized. About a quarter of the patient's definitive radiation was used, and another quarter of the patient's surgery plus radiation was used. And actually, the patients who received definitive radiation had a higher local failure rate, but the event-free survival was essentially the same. So you can see here the different trials in North America and the time eras. And as we go, to the more modern eras, you can see that we have a reduction in the target. At first, we were treating around 2 to 3 centimeter margins, and then 1.5 centimeter margin for the CTV in AEWS 0031. And most recently in 2010, we started using a 1 centimeter margin on the initial tumor. So the dose has been about the same. It's been 55.8 gray for patients with gross tumor. But if we were treating microscopic margins, then we would give a dose of 50.4 gray. So this is an example of a case. This is a patient with a left iliac wing Ewing sarcoma. This is the gross tumor volume at initial diagnosis, which will get the 45 gray. If we add 1 centimeter margin, this is the clinical target volume. And then you can tailor the clinical target volume according to the anatomy of the patient. For example, we know the tumor is not going to go to the bowel, so we don't have to extend the clinical target volume to the bowel. This is the same patient, and this is after 12 weeks of chemotherapy. The tumor had shrunk some, and this is the gross tumor volume 2. You can see the differences between the gross tumor volume 1 and gross volume tumor 2. And this is the clinical target volume 2, which is 1 centimeter addition to the gross tumor volume 2. So this big area is the one that gets 45 gray, and then the boost is 10.8 gray. So now let's look at some dose escalation for larger tumors. So initial experience at St. Jude showed that 30 to 36 gray for less than 8 centimeters had 90% local control. However, when they followed their patients, longer time period, they found that less than 8 centimeters tumors that were treated less than 40 gray had higher rates of local failure. And you can see here this less than 8 centimeters treated with less than 40 gray, and this is with more than 40 gray. But what's interesting in this particular graph is what about the greater than 8 centimeter tumors? And so you can see here, greater than 8 centimeters, whether they were treated with less than 40 gray or more than 40 gray, the local recurrence rate was pretty high. And Beate already showed this particular study that as you have a bigger tumor, you need more dose to control, that particular tumor. So at St. Jude, they had a phase 2 study of limited margin radiation and also dose escalation. So they had 45 patients in this particular study. And the patients that were less than 8 centimeters received 55.8 gray, which is the standard dose given in North America for definitive radiotherapy. And those that were greater than 8 centimeters received 64.8 gray. Patients who had microscopic margins after surgery received 50.4 gray. The other interesting thing in this particular study is for the first 45 gray, they used 1 centimeter margin for the clinical target volume. But for the boost volume, they really didn't add, any margin. And so you can see here the local failure rates. What was observed was it was a 4.4% local failure rate, 7.7% for the patients treated with 55.8 gray, 5.9% for those 50.4 gray, and there were no local failures in those receiving. So those 12 patients who received 64.8 gray, there were no local failures. This is a study from University of Florida where they also dose escalated some patients. So these are 35 patients with localized pelvic Ewing sarcoma. 26 of these patients were treated with definitive radiation therapy. And what's interesting in this study is until 2017, they were treating 54 to 55.8 gray for definitive radiation therapy. And then after 2017, they started using higher doses, 57.6. And then the most common dose was 64.8 gray. And interesting in this study that although 2 local failures occurred in the 26 definitive patients, those were patients who got the lower dose of radiation, and that all the 5 patients with greater than 8 centimeters who received at least 59.4 gray to 64.8 gray were locally controlled. So in North America, this is a subject that is being talked about in the radiation committee about those escalating larger tumors. And finally, I just want to touch on the use of radiotherapy for metastatic disease. This is a single institution study of 30 patients with metastatic Ewing sarcoma. The 5-year overall survival is 22%. But what's interesting, if you look at the patients who survive in this small study, is that the patients all received local control therapy, either with surgery or radiation, but the metastatic sites were also treated with radiation therapy. So in the COG AEWS 1221 for metastatic disease, radiation is recommended to all non-marrow metastatic sites. However, we do understand that the more metastases that you have, the efficacy of delivering radiation to these metastatic sites probably goes down. So, and also this might be related to too much toxicity if there's too many metastatic sites. So the treating radiation oncologists have to decide which metastatic sites have to be treated if there are too many. And in this particular study, surgery is also an option for metastatic sites if it can be done with low or acceptable morbidity. So if you have too many metastatic sites, the recommendation is to treat only those sites which had either suboptimal response to chemotherapy by clinical or imaging criteria at the end of all the chemotherapy, or if a recurrence in that particular metastatic site will be problematic in the event that they were to relapse in that particular site. Also, that metastatic site has to be imaged well, and you can see the tumor very well. And finally, the patient should be able to tolerate the treatment reasonably. So for pulmonary metastases, the recommendation is to give 15 gray in 10 fractions to the bilateral lungs in children greater than 6, and 12 gray in 8 fractions to children less than 6. And then for the metastatic sites that are greater than 5 centimeters, and also those that are less than centimeters that are not bony metastatic sites, the recommended dose is similar to what we would give for the definitive cases. So 55.8 gray for gross disease and 50.4 gray for positive margins. And if you have a complete response to the chemotherapy, 50.4 gray. So one of the things that's different in the AEWS 1221 is the use of stereotactic body radiotherapy for bone mets less than 5 centimeters. And in this particular case, you give 40 gray delivered in 5 fractions. So each treatment is going to be 8 gray per fraction, which is pretty high. And just because I know there are a lot of people who are not radiation oncologists in the audience, I just give you some differences between conventional radiation therapy and stereotactic body radiation. So the fraction site that we use, the daily treatment that we use for stereotactic body radiation therapy would be anywhere from 5 gray to even 24 gray if you give it in one single fraction. Whereas with conventional radiotherapy, you give 1.8 gray per day. And you see here the total dose is much less with stereotactic body radiotherapy, but it is given in a shorter duration of time compared to the conventional radiation therapy. And it is thought that this is more beneficial for more radio-resistant tumors like sarcoma, melanoma, and renal cell carcinoma. And there is a size limit for stereotactic body radiotherapy. So usually it has to be less than 5 centimeters. And this is just literature in adults treating bone metastases with stereotactic body radiation therapy. And these are different histologies. And you can see here that most of the studies have 1 to 2 year local control rates of 80 to 90%. This is an example of a patient that we treated with stereotactic body radiation therapy. The patient had an amputation as the primary local control and finished chemotherapy. And then 1 year after completion of chemotherapy, had relapse over a year in the iliac bone. The metastatic workup was otherwise negative, so it was only one site of metastases, and the biopsy was also Ewing sarcoma. So in our multidisciplinary tumor board, we discussed the case and we decided that we were going to give radiation therapy. And because the target is so small, we decided we're going to give stereotactic body radiation therapy. This is right iliac lesion. And the question here is, do you treat the initial bone and soft tissue at relapse? Do you treat just the residual abnormality in the bone after the chemotherapy? In this particular case, the patient's soft tissue involvement disappeared after the salvage chemotherapy. So we decided just to treat the bony lesion. And you can see here in red where the bony lesion is located. We added a 1 centimeter margin on this particular case because of the soft tissue involvement. And we gave a higher dose to the red volume, which is 27 gray in 3 fractions. Okay, and while we were treating this with 27 gray, this bigger margin here is getting 21 gray, so simultaneous integrated boost. So this patient actually was locally controlled, but the one thing that's good about SBRT is you can see, these are the doses to the target on this dose volume histogram, and these are the doses in normal critical structures, which are far away from the DVHs of the target. So there has been some experience with using SBRT in Ewing's. This is a Mayo Clinic study of 3 patients and 5 sites that were treated. And you can see here, the fraction sizes that were used for, around 6 gray to 7 gray per fraction. And in this 5 sites that were treated, there were no local failures from 2 to 4 years follow-up. So for whole lung radiation therapy, now we have an option aside from just the APPA fields. So this is the traditional whole lung radiation therapy where you give radiation from the front and back. And when you do this, you're not only treating the lungs, but you're also treating the entire heart, with a full dose of radiation. So one of the things that has been done is use intensity modulated radiation therapy to help spare the heart. And this is a paper, a multi-institutional paper, looking at the feasibility of this approach. And you can see here, for example, 95% of the prescribed dose is being delivered to the heart in all patients with APPA fields, but if you use, intensity modulated radiation therapy, only 39% of the heart is receiving 95% of the prescribed dose. So the difference between the conventional radiation is that in the intensity modulated radiation therapy, it is like a jigsaw puzzle. You have these little pieces of the jigsaw puzzle, and each piece of the jigsaw puzzle, you can vary the intensity of the radiation. And when you can vary the intensity of the radiation, you can make the radiation more conformal to your target. So this is just looking at the different studies in North America and looking at what is allowed as far as radiation therapy. And of course, brachytherapy is something that is, quite old and has been allowed for a long period of time. Intensity modulated radiation therapy was allowed in the early 2000s. And then proton therapy was allowed in 2010 for the localized study. And then finally, SBRT was just allowed in 2014 for the metastatic bone sites less than 5 centimeters. So of course, with all this different technology, it's very difficult when you have multiple centers with different radiation oncologists treating these patients. And so each center, in order for them to treat with MRT, proton center, and stereotactic body radiotherapy, they have to submit some data. So they have to pass a test. And the IROC facility in Houston, which is in the same facility that I work at MD Anderson, gives them a case, and they return the case with a treatment plan. And then it will be reviewed, and basically you have to pass it in order to be able to treat patients, with this, more advanced technology. The other thing is, after you have treated the patient, you also have to send, the data, the radiotherapy data, including the treatment plan, to the Imaging and Radiation Oncology Core in Rhode Island to be reviewed by the radiation oncology primary investigator. So in conclusion, modern North American studies are utilizing more limited radiotherapy volumes, often with 1 centimeter margin from gross tumor bed to create a clinical target volume. Single institution studies show that dose escalation for tumors greater than 8 centimeters is feasible with excellent local control rates. And modern techniques such as MRT, proton therapy have been used to minimize toxicities associated with radiation therapy. And SBRT to bone metastases is currently being used in cooperative studies. And aside from Ewing's, we're also using SBRT in rhabdomyosarcoma patients. So thank you for your attention.
Thank you again for this great talk. We're a little bit over time, but I would like to ask one of the 3 questions from the chat. The first is, do you include symmetrically sacrum in younger children when PTV is partially within sacrum?
Yeah, so I actually don't. And the reason is because you're going to be radiating, more normal tissues. When you try to make, your target symmetrical, usually in the sacrum, the tumors are very large to begin with. And when you add a margin, it's pretty much you're treating most of the sacrum anyway. So I don't really, think about it and say, okay, I have to cover the sacrum so I can avoid a certain late effect.
Okay, thank you. Thank you again for joining us so early. So it's highly appreciated. I now hand over the chair to Anna. Thank you.
Hello. And now we are very pleased to invite the next speaker, Philippe Hassan from Switzerland. Philippe is a medical student from Zurich who does his thesis in our group, analyzes the Ewing 2008 data, and he will show the first results. Floor is yours, please.
Thank you very much. I'll try to share my screen. Okay, I hope the screen is visible now. Okay, excellent. So yes, thank you very much for allowing me to present the results of our secondary analysis of the Ewing 2008 trial concerning local treatment modalities. I've already been introduced, but briefly, my name is Philippe Hassan. I'm a medical student in Switzerland, and I've been helping Uta Dirksen and the great team with this analysis. Now, in this short presentation, I want to introduce our research question, then talk about the methods that have been applied in the Ewing 2008 trial and the methods that we have used for our analysis concerning local treatment modalities. And then I'd like to present our preliminary results and try to put them a little bit into context. So the research question, the main research question was whether there's a difference in outcome, which I'll specify between either of the three local therapy modalities, which are surgery only, radiotherapy only, so definitive radiotherapy, or combination therapy, so a combination between surgery and radiotherapy. And the primary outcome that we looked at was event-free survival, and our secondary outcomes were overall survival and then local control, local recurrence-free survival. The patients that we have included were all part of the Ewing 2008 trial. Now, the Ewing 2008 trial included patients with histologically confirmed Ewing sarcoma. They all had first-line treatment. This was 6 cycles of VD chemotherapy. And patients in the Ewing 2008 trial were then randomized into one of 3 arms, R1 to R3. And we only included patients in our quantitative analysis that were part of the R1 or R2 localized group, so patients with localized disease. 1,421 patients were registered in the Ewing 2008 study. We excluded 558 of those, either because they presented with metastasis at the time of diagnosis, or they had missing data, or the event was before local therapy, this due to our event-free survival being our primary outcome. So we included 863 participants in our analysis. 375 of those received a combination therapy of surgery and radiotherapy. 331 received surgery only, and 157 received radiotherapy. The methods that we have used for the analysis were we have calculated Kaplan-Meier scores and drawn Kaplan-Meier curves. Then after assessment of proportional hazards and log linearity assumption, we have performed Cox regression and thereby calculated unadjusted and adjusted hazard ratios, which are then specially presented in the paper that we're currently writing. One of our other research questions was which patients would benefit from which therapy. So in this case, I would like to present 3 subgroup analyses that we have conducted. One was large tumors, in this case being defined as a tumor volume above or equal to 200 milliliters. Then poor histological response to surgery, being defined as having more than 10% vital tumor cells after surgery, and then also tumor of the pelvis. Now, when looking at the overall results of the Ewing 2008 trial, you can see Kaplan-Meier curves here, depicting the survival probability on the y-axis and the time in years on the x-axis. When looking at event-free survival for all patients, 5-year EFS was 70%, while it was 82% for overall survival, and then 92% for survival without local recurrence, so local control. Now we went ahead and stratified patients by the local therapy modality that they have received. You can see event-free survival here. Radiotherapy on the left, radiotherapy is depicted in green, and then there's surgery in orange and the combination therapy in blue. And here it's visible that patients with radiotherapy had worse event-free survival than patients treated with surgery alone or combination therapy. Please see that in this case, I zoomed in a little bit on those Kaplan-Meier curves. So the y-axis starts at 50% survival. And we see a very similar picture when looking at overall survival, though probably the effect was not as big, the effect of radiotherapy performing a little bit worse. And then also looking at local control, local recurrence-free survival, we see crossing hazards here or overlapping hazards. So it's a bit more difficult to interpret what therapy was best actually when looking at local control. So now I want to start with the first subgroup analysis, which is tumor volume. So we know from a systematic review that tumor volume is a strong prognostic factor. There are different cutoffs used to describe what a large tumor or a large tumor volume actually is, ranging from 100 to 200 milliliters. This might explain some difference in outcomes between studies and different findings. And the question we ask is whether patients with large tumor volume, whether these patients actually benefit from additional radiotherapy. Now, the first thing that we wanted to look at was whether having a large tumor volume was also a prognostic factor in our cohort. So here we stratified patients by tumor volume. Low tumor volume being defined as below 200 milliliters is depicted in green, and then above or equal to 200 milliliters depicted in orange red. So you see that patients with a low tumor volume had better event-free survival compared to patients with high tumor volume, also better overall survival depicted on the right-hand side at the top, and also better local recurrence-free survival. But again, the effect in this case was not as strong. So we concluded that also in our case, tumor volume was a prognostic factor. Now, when stratifying patients that had a large tumor, so only looking at those patients by the local therapy, the modality that they have received, we can again see that radiotherapy performed a little bit worse, and then surgery and radiotherapy and surgery performed pretty similarly. Then at the end of the follow-up period, you see those curves separating a little bit, but it's very hard to estimate due to many people having been censored before that to actually estimate this precisely. So we're not very confident in this actually being true of a late effect of surgery and radiotherapy. But we conclude that in this case, event-free survival was pretty similar for combination therapy and surgery. And we also see a similar picture when we look at overall survival, and again, local recurrence-free survival. So we saw that patients with a large tumor volume did not benefit from adjuvant radiotherapy. We saw that when looking at radiotherapy only and comparing this to surgery only, it increased the hazards of any event, but not all-cause death or local recurrence. And we see that tumor volume was a prognostic factor, where 5-year event-free survival and overall survival were decreased by roughly 10%, and local recurrence-free survival was decreased by 3%. Now I want to turn to the second subgroup analysis, which is histological response to surgery. And there's a very interesting consensus paper published in 2020, describing that there was strong consensus that decision about radiotherapy can await assessment of histological response. And there's moderate consensus that poor histological response requires post-operative radiotherapy. So again, our questions were whether histological response was a prognostic factor in our patient population, in our cohort, and whether patients with poor histological response benefited from adjuvant radiotherapy. So again, we differentiated between patients with good and poor histological response. Poor histological response being defined as having more than 10% vital tumor cells after surgery. So we see that for event-free survival, patients with poor histological response had worse event-free survival and also worse overall survival and worse local control. And now note that histological response to surgery, of course, was only available for patients that were treated either with surgery only or with combination therapy. So we then went ahead and stratified patients by one of the two possible local therapy modalities that they might have had when they had a poor histological response. And we see that actually having an adjuvant radiotherapy, so radiotherapy after surgery, did improve event-free survival compared to patients that only had surgery. It also improved overall survival, and it improved local recurrence-free survival. So to summarize, patients with poor histological response did benefit from an adjuvant radiotherapy, and histological response was a strong prognostic factor, with event-free survival and overall survival roughly decreased by 20%, and local control, local recurrence-free survival decreased by 3%. Now turning to our last subgroup analysis that I'd like to present. This is pelvic tumors. Again, we know from a systematic review about prognostic factors for Ewing sarcoma that there's moderate evidence that pelvic location is a prognostic factor for poor survival. It has been suggested that combination therapy might be beneficial for overall survival compared to radiotherapy only. It's also been shown that there's problematic local control, and it's been suggested that there might be worse local control after radiotherapy only. And then there's been inconsistent results whether the size of the tumor, in our case measured by the tumor volume, matters in pelvic tumors. So when looking at patients with tumors at different locations, we see that patients with tumor at the extremity had a very good event-free survival, and then patients with tumors of the pelvis had a worse event-free survival, here depicted in orange, and also same for overall survival. And we see that in the middle, you can see other locations. So pretty similar picture for event-free survival and overall survival, and then also for local recurrence-free survival. Now, again, stratifying these patients by the local therapy modality that they have received, you see, again, radiotherapy performing a little worse, and surgery and radiotherapy compared to surgery pretty similarly, concerning event-free survival, concerning overall survival, and then also concerning local recurrence-free survival. Now the question was whether size matters in pelvic tumors. So we only took patients with pelvic tumors and stratified those by tumor volume, small and large. And we see that up until roughly 6 years, tumor volume actually is a prognostic factor also in pelvic tumors, and patients with large tumor volume had a worse event-free survival and overall survival, and likely recurrence-free survival. So to summarize our findings regarding pelvic tumors, radiotherapy only was inferior to surgery or combination. Small pelvic tumors were associated with better survival. Event-free survival, overall survival were increased by 10%. There was no difference in local recurrence. So size of tumor likely matters in pelvic tumors. And there was no difference in local therapy regarding local control. The conclusions of our analysis were that event-free survivals were decreased after definitive radiotherapy compared to combination therapy, but not compared to surgery only, and that patients with large tumor volume did not benefit from adjuvant radiotherapy, but patients with poor histological response, those patients did benefit from adjuvant radiotherapy. And patients with pelvic tumor had worse event-free survival after definitive radiotherapy compared to surgery only. So thank you very much.
Thank you very much for your interesting presentation. I am impressed with your work. Any comments or questions from the audience?
I think there are some questions in the chat, Anna.
Okay, some questions in the chat, but okay, Shamuta. Why local treatment modalities have an impact in survival independent from local control? This is Uta asked about comments. I can see any other question or comments.
There was a question from Beate.
No, I think that this is comments to radiation. To radiation presentation.
Dimo's raising his hand.
No, it was about this talk. I asked about the matched pair analysis. This is for Philippe Hassan.
Right. Okay. I'm going to read the comment. Would it be feasible to go into a matched pair analysis? Better any co-advice when looking into radiotherapy with data in this study? Yes, I think some of the other analysis that we have conducted, we have not presented in this presentation, but we'll present those in the paper.
Okay. No comments. No.
Perhaps if I could make a comment regarding Uta's question, because we've discussed this in the past. There have been some small studies coming from the US suggesting that in case of an inadequate local control, you may have some microscopic disease in the case of a local primary, which for whatever reasons it may be, does not lead to a local recurrence, but still affects the prognosis of the patient. So their suggestion was that we need to be more aggressive for a local recurrence to make sure we get all the residual tumor cells and possibly affect prognosis of the patients, even if we don't see local recurrence in this patient. Obviously, it's very difficult to prove this, but it is at least one possible explanation.
Maybe we have to ask Markus and Eleni whether they see some circulating tumor cells still flooding in the blood. Maybe it's like that. But it's really, but we have seen that before, even in these old papers by Andreas Schuck and so on, that that you improve survival by local treatment without yeah, and real impact in the local control.
If I could ask one last question to Ms. Hassan. First of all, great presentation. Thank you very much for that. Did you have a chance to examine the impact of additional radiotherapy on patients with a good histological response to induction chemotherapy?
Yes, I remember we also looked at this, but we didn't see much of an effect there. I think we'll also show this in the paper, but we did not see any great effect compared to worse response.
Okay. No other questions. Many people congratulate your job.
Thank you.
Again. And we start the second part of this session, case discussion, surgery versus radiation. I think that many of us often ask ourselves what to choose for our patients. It's one of the most important patients for me and for my patients, surgery or radiation or maybe both. Then I believe it will be very important part of this session for many of us. So it's great pleasure to invite Daniela Greto from Italy.
Hi, good morning. I'm Daniela Greto. I'm from the University of Florence. It is a pleasure for me to present you some cases about pelvic and spine sarcoma. First of all, why we choose this argument? Because we know that from the previous talk that pelvic and spine Ewing sarcoma had a worse outcome compared to extremity, because the standard approach to local control is still controversial, because we know that prior to 1980, radiation was the main treatment, but now we know that from different studies that surgery improves local control. And one of the most thing is that caveats in clinical studies, low samples, dissimilar course, varying chemo regimen, and lack of randomized trial. First of all, I will present you two cases of pelvic localization. The first one was a young male, 12 years old. He had a medical history negative. His history started on March 2018. He had onset of swelling and pain of the left pelvis after a football match. It was poorly responsive to paracetamol, but at clinical evaluation and at ultrasound, there was a diagnosis of intramuscular hematoma. But due to the resolution of the pain, of the clinical increasing of the lesion, he underwent on August to an MRI that showed a mass of about 10 centimeters originating from the left iliac bone, extending inside the small pelvis with infiltration of the muscle. Here on the right, you can see the MRI with the T1 and T2 sequences. After this, he was referred to our pediatric hospital, the Mayer, and underwent a sedation with a PET CT that showed an area of uptake in the gluteal region with the iliac and the bone and the iliac fossa with an high bone uptake and a moderate uptake in the soft tissue. The thorax CT with contrast was negative for distant metastasis. After this, he underwent a bone biopsy that showed a diagnosis of Ewing sarcoma with the gene fusion of the Ewing fly1. The bone marrow aspirate was negative. After this, the patient started induction chemotherapy according to the ISG-IERP-EW1 protocol, so he underwent 4 cycles of chemotherapy. After this, we performed the MRI after induction chemotherapy. There was a partial response of the lesion, about 2 centimeters, and we saw that there was a necrotic area in the soft tissue, and the bone portion had a mass with a necrotic central solid region with a minimum post-contrast enhancement. The thorax CT was negative. So there was the NTD discussion, no indication for surgery due to dimension of the lesion, the extension to the soft tissue. And so it was decided to go on with the consolidation chemotherapy, followed by preoperative or perhaps radical radiotherapy, and after a surgical evaluation. The patient underwent a consolidation chemotherapy for 4 cycles, and after we performed preoperative radiotherapy. First of all, we use 3D conformal radiotherapy for the dimension of the disease because it was very lateral, and to reduce the low doses using an IMRT approach due to the young age of the patient. We choose a 45 gray total dose, so a preoperative one, to avoid the possibility of wound complication in case of surgery. We usually perform hyperfractionated accelerated radiotherapy, so 1.5 gray twice daily. The patient underwent a PET CT after radiotherapy and consolidation chemotherapy with a complete metabolic response. At this point, the surgeon decided to perform the surgery to the patient. It was the primary tumor at the CT, MRI, and PET, and the surgical planning. They decided to do a 3D printing titanium custom-made prosthesis. This is the reconstructed CT to do the prosthesis, and this is a video showing the surgical modality, so the resection of the bone, the titanium prosthesis, and bone massive allograft. After this, the CT reconstruction at the end of the surgery, and the controlled CT after surgery. The histology was a grade 3 pitchy response. The margins were negative, so a wide excision. After this, the patient underwent to high-dose chemotherapy with autologous peripheral blood mononuclear cells rescue, and at the last follow-up, that was on September 2021, the patient was negative. The second case is about a 26 male. He had a medical history negative, and his history started on June 2017 due to onset of pain in the lumbosacral region treated as disc protrusion. On July 2017, he underwent a neurosurgical evaluation, and the neurosurgeon requested an MRI that showed a pathological tissue with an extension of about 9 centimeters, occupying the right sacroiliac joint and the first and second sacral foramina. After this, the patient was referred to the Meyer Pediatric Hospital, where he underwent a staging CT and a PET that confirmed the pelvic findings and diagnosed multiple and bilateral lung metastasis. The max diameter was 1 centimeter. That was our target lung lesion. He underwent bone biopsy with a diagnosis of Ewing sarcoma, a bone marrow aspirate that was negative. After this, he started induction chemotherapy following ISG-W2 protocol with 2 cycles of Temiri, VAI, CE, VAI, and CE. After this, he underwent an MRI that showed a reduction of about 3 centimeters of the primary lesion, but always the involvement of the right sacral wing, obliterating the right conjunction foramens, and a thorax CT with a minimum reduction of the lung metastasis. After NTD discussion, it was decided for the localization and involvement of the foramen for definitive radiotherapy. In these cases, we perform an IMRT plan with helical tomotherapy and daily IGRT with 54 gray of total dose, always with the hyperfractionated accelerated radiotherapy 1.5 gray twice daily. After this, the patient underwent consolidation chemotherapy, and post-induction MRI and PET-CT show a stable dimension of the local and distant metastasis, but with a complete metabolic response of the primary. On May, he underwent high-dose chemotherapy with busulfan and melphalan with the autologous PBMC rescue. On November, the local MRI was stable and thorax CT showed response of the lung target lesion with a residual millimetric calcified nodule, so it was decided to undergo total lung irradiation. In these cases, we decided to use an IMRT plan, always with helical tomotherapy for 15 gray in 10 fractions. In this way, we can obtain the maximal avoidance of the heart and the vertebral body. After this, the patient started follow-up. He was stable until August 2019, when a thorax CT and PET-CT showed the lung relapse with a stable disease in the sacrum. There was no indication to surgery, and so the patient underwent the first-line chemotherapy. He performed 7 cycles of Temiri. And after a partial response, he had an oligoprogression of lung disease, and at this time it was decided to perform a bilateral atypical pulmonary resection and lymph node sampling. On April, the patient had a lung progression, no surgical indication, and so it was started second-line chemotherapy with 9 cycles of high-dose ifosfamide following the RECUR trial. After this, the patients on March underwent lung progression, and so it was indicated a third-line chemotherapy. He performed 9 cycles of irinotecan and deribulin that was off-label, and on September 2021, due to the lung progression and worsening of the quality of life, chemotherapy was stopped and the best supportive care was started. And go on, one case about a spine Ewing sarcoma. In this case, a young man, 13 years old, he had a medical history negative. On January 2015, he had an onset of pain in the dorsal and lumbar spine, irradiated to the left lower extremity, poorly responsive to analgesic. On February, he underwent an MRI that showed a complete replacement of the 11 by newly formed tissue invading the right portion of the spinal canal, causing compression of the medullary cord. The CT, the total body CT confirmed the lesion. It was negative for metastasis. I'm sorry, but I haven't the image of the baseline MRI, but only of the CT. So the patient was referred to the Mayer, and he had an emergency surgery with a decompressive laminectomy and bone biopsy. As in this case, we have a diagnosis of Ewing sarcoma with a EWS1 gene fusion present. The bone marrow aspirate in this case was positive with the presence of the translocation for Ewing. A PET-CT showed a high uptake involving the anterior portion of the dorsal spine, D10 and D12. And here you can see the post-laminectomy PET. It was started the induction chemotherapy following the protocol ISG-W2 protocol with 4 cycles, and after the MTD discussion decide for radical radiotherapy. In this case, the patient started radiotherapy with an IMRT plan. There was an error. It was not helical tomotherapy, but a VUMAT, volumetric modulated artery radiotherapy. The patient received a dose of 45 gray on all the primary tumor with a boost in the extramedullary portion of 54 gray to avoid the spinal cord. Always with an hyperfractionated artery radiotherapy, so 1.5 gray twice daily, and with daily IGRT. The thorax CT showed a stable spinal disease and no distant metastasis. So the patient underwent consolidation chemotherapy for 4 cycles, and after this, as you can see below, the baseline PET-CT and the post-radiotherapy consolidation and chemo PET-CT showed a complete metabolic response of the target primary. From January to February, the patient underwent high-dose chemotherapy with autologous PBMC rescue. He underwent maintenance chemotherapy with cyclophosphamide and celecoxib for 6 months. And after, he underwent the PET that was always stable with a negative metabolic disease in the D11 and the negative distant metastasis. Thereafter, patient started the follow-up and came back to his fatherland. Our last follow-up was on November 2017, and he was disease-free. So what we can learn from the BUS, that absolutely for pelvis and spine Ewing sarcoma, definitive radiotherapy was the main treatment. But also we know that the addiction of surgery absolutely increase the outcome of these patients in terms of local control and overall survival in the past studies. But when we look at the study, like just said from the previous speaker, patients receiving radiotherapy alone represented a negatively selected subgroup of the studied population or the study for the site, the size, the age of the patients. So the challenge of the future could be that whenever feasible, surgery must be done, that in case of poor histological response, intralesional or marginal resection, we have to think to postoperative radiotherapy. If we have expected close margins, preoperative radiotherapy could be an option. That surgery, if surgery is not feasible, definitive radiotherapy could be suggested, and if possible, a dose escalation. And in this case, we will wait for the Euro Ewing trial. Well, thank you to our little patients and their families, to my colleagues, and to all of you for the attention.
Thank you for your presentation. Any question or comments from the audience? One question. When do you use heart, and when to go for preoperative radiation in Italy?
We usually use heart for all Ewing sarcoma, because in our trial we usually use hyperfractionated radiotherapy, because we think that we have less late toxicity, and it is a protocol for us. For preoperative radiotherapy, we usually use it in case of not immediate indication to surgery. For the first case, I say pre-op or radical, because in some cases the surgeon are not so comfortable to say absolutely yes, surgery after all the treatment. In some cases, we decided to do preoperative after consolidation radiotherapy, and in case of no indication to surgery, we can boost until arrive to 54 grays. We don't go up to 54 grays in the radical setting.
And we have questions about place autologous bone marrow transplant in your patients.
Sorry?
Questions about place autologous bone marrow transplant in your patients. If always needed, how is your opinion? And
I have to say that it is all about the oncologist, the oncohematologist, the pediatric oncohematologist, and radiation oncologist, but we usually do it in high-risk patients.
Okay,
maybe I can support. So I think that at the time of the patient of 2015, in case of lung-only metastasis, we adopted the ESG V2 trial, which also included bone marrow transplant. Now off trial, after of course, the results of Euro Ewing, we use it only in the setting of poor response in a patient with the localized disease. And in the case with bone marrow involvement, I think we never did. Maybe it was a patient decided option for multidisciplinary group reason, which I don't know.
What about using Bummel regimen together with axial radiation therapy? Because it could be controversial to use Bummel and axial radiation therapy. What is your opinion?
Yes, we have seen that in Europe there are a lot of reluctance to use busulfan and melphalan and radiotherapy. I have to say that in particular in axial, we have very low dose to the lung, and we have no late or acute effect. So I can say that with VUMAT, with new technologies, we can limit the dose to the lung, absolutely.
And for busulfan toxicity, I can add that in Italy, we sometimes use triosulfan in selected cases, but again, out of trial.
Thank you for response. And I can see any question or comments. So we are pleased to invite our last speaker in this session, Andreas Leitner from Austria, from Medical University of Graz, specializing in the field of orthopedic oncology. Floor is yours.
So thank you. So this talk is on radiotherapy versus surgery. It should be a case discussion on a thoracic sarcoma case. And this is the case, a 17-year-old male patient. I can see here the fourth rib on the left side is missing. You can see also that the tumor is pushing away the third rib and also the fifth rib. The patient then came to us with this CT, where I can see that the area of the left lung has nearly been obliterated. And also the patient reported about pain in the left shoulder and a fever up to 39.4 degrees for the last 3 weeks. So it's a pretty big tumor. And we looked on the bone image of the CT. You can see here the fourth rib is missing. We have also then done an MRI, and the primary tumor is originating from the fourth rib. And there are two areas of interest for me as a surgeon. One is here on the front, where there's a close vicinity to the vessels. And the second is here, where we have an invasion of the spinal canal. And the biopsy was done, so, sorry, the milliliter was about 980 milliliters, but no metastasis in staging. Biopsy in the frozen section, this is a later one from resection specimen, but you can see here the small round blue cells. They're definitely malignant. And the children's oncologist started with chemotherapy on the next day. The volume was 980 milliliters and we didn't have any metastasis. Some days later, a week later, the next generation sequencing came in and confirmed the diagnosis of a Ewing sarcoma with EWSR1 FLY1 fusion. And this is the restaging after 4 blocks of chemotherapy, according to the protocol. And here again, we can see a reduction of the tumor volume of about 70%. The volume now is about 290 milliliters. But I think, according at least to my thinking, we still have a problem because we have an invasion still of the spinal canal. And then we had the tumor board, and Martin Benesch, our children's oncologist, who's also here, said operation first. We have to stick to the protocol because we need a regression grade for deciding how to go on after the operation. The children's surgeon said, no problem. We don't care if it's R0 or R1. We can do post-op radiotherapy. And I said, we need R0 margins, therefore radiotherapy first, and then surgery. And the radiation oncologist said, as you like, we'll do whatever you want. So we had a problem because we had a hot discussion going on. So now please take out your mobiles, and I hope this works. So please, we have a voting now. You are in the tumor board, and you can now help me decide if what we did was good or not. And there should be a question. The role of, it should be, hope, no, this, sorry, it should, okay, this is the next question. So I think now you have the wrong question. Normally the question should be, go for surgery, pre-radiotherapy or radiotherapy or something else. Yes. Okay, please vote. Hope this changes. Yes. Should some votes come in? Okay, most for preparation to the therapy, 1 for surgery. Radiotherapy alone, also an option. I'll just wait for some more seconds if someone else wants to vote. Okay, so we had a problem, and that's why we asked the study center. And this, of course, was Ute Dijkstra and Jens Kaders, and we asked them the same question and sent the pictures there. And they had a tumor board, I think 2 or 3 weeks later, and said neoadjuvant radiotherapy is okay. And I said, thank you. And I still say thank you for the perfect collaboration with the study center. So we started with radiotherapy with 50.4 grays in small dosages. And this was where the images just pre-op. We had a reduction of, in total, 82%. And the tumor volume was now 175 milliliters. And you can see here, it looks better concerning the spinal canal. and that's why we chose the resection. This was the poster picture. You can see here 5 ribs are missing. This was the resection specimen. Fortunately, we had R0 margin with a minimal resection margin of 1 millimeter, which at least in my opinion is okay. And these were the pictures at histology where you can see still nests of Ewing sarcoma, and it was a regression grade 3. So yes, but this regression grade 3 was despite pre-radiotherapy. We have to consider that. The study, the story went on and is still ongoing, and we had complications. But this is another story, and if we look at the picture we saw from Demos, it's kind of a big problem because we're now over those 22 days after surgery, and chemotherapy should start. So what can we conclude from that case? And I think because this is only a case, we can conclude nothing. But if we, together with the things we have heard yesterday, and one of those things was presented by Professor Myers from the States, that Ewing sarcoma was detected by James Ewing because of its response to radiotherapy. I think we should think that radiotherapy, I think we don't only have to think, we know that radiotherapy is working for those tumors. And if we look at the publication from Demos on pelvic, of course, pelvic sarcomas, we can see that surgery and radiotherapy were doing best, a combination of both. So I think we know that there is a role for adjuvant radiotherapy. We know those cases where we need adjuvant radiotherapy, especially when the margins are not okay. We have heard that there is a role for definitive radiotherapy, especially in palliative cases or pelvic cases or some spine cases. What we do not know is there a role for adjuvant radiotherapy. And again, please take out your mobiles. And the question I want to ask you, should treatment protocols include the possibility of neoadjuvant radiotherapy for patients when R0 resection is improbable despite neoadjuvant chemotherapy? So just say yes or no. And we will have a look. Oh, this is now, so it's more yes at the moment. My slide is not perfect, I see. Most say yes, that's wonderful. Thank you for that. And the next question is, should the role of neoadjuvant radiotherapy for Ewing sarcoma should be evaluated in randomized controlled trials? Again, please vote. Oh, that's perfect. So I think we really should think, or I hope that me as a surgeon, that one day radiotherapy might help us do better surgery or even allow us not to do surgery at all. And I think it would very, very good to have good trials for neoadjuvant radiotherapy for Ewing sarcoma. And with this, I would just like to think what Professor Jürgens yesterday said, that a combined local treatment is preferable for Ewing sarcoma. I think this is very, very important. If we look at carbon ion radiotherapy, there's a nice publication, but only with 5 patients from Japan, and 4 of those had good, at least stable disease or good response. But we can see here that there was no change in 3 of them and local failure in 1 of them. So, but we need, I think, pretty much more data on carbon ion therapy as we heard before. So another question I would like to have answered within the next 10 years, what is the role of proton beam radiotherapy or even carbon ion radiotherapy for the treatment of Ewing sarcomas? So in the end, my conclusion is it's not radiation therapy versus surgery, it's radiation therapy and surgery. In the end, thank you, and let me invite you to the EMSUS conference next year in London. Thank you.
Thank you very much for excellent and very informative presentation. We have question about non-adjuvant concomitant radiation together with chemotherapy. And I think that this is question about intensity of chemotherapy when preoperative radiation is used. What is your, maybe not your, but maybe Uta opinion about doses, and how is possible to to use together preoperative radiation and intensive chemotherapy? Question maybe to Uta, not to
Uta or Martin, you could also answer.
I don't know. Who wants to go first?
Uta, Professor Dixon.
I think that we sometimes reduce chemotherapy when use radiation. And this is question about possibility. I think reducing the adjuvant chemotherapy and how it will be impact on our patients. And of course, the other.
I think, to be honest, I mean, this is not really evaluated yet, because usually the drugs that we use in a neoadjuvant setting are not applicable to be used together with radiotherapy. So we would need to switch like everything. However, what is usually done is to do in the adjuvant setting to use a combination.
Something else, because I have one comment to this about when we will be using adjuvant radiation, we can be careful when we will be evaluate response to neoadjuvant chemotherapy, of course.
Yeah.
I think that this is our problem also, and we should discuss this very, very carefully. What is our opinion about this?
Yeah, that's always the discussion, because most of the radiotherapists would like to have neoadjuvant radiotherapy because the field is smaller than if you do it after surgery, but we lose the knowledge whether we have a good or poor histological response. And I mean, Philippe, in his analysis, also showed nicely that also in the Ewing 2008 trial, we still have this as the most relevant. It's kind of a biomarker for outcome, and that this is something we would lose then. Yeah.
Okay, we after time. No comments and question now, though we end the session. Thank you very much also.
There are two more comments from... Yeah, maybe we have two more comments from Beate and Dimo. I think we could take the time.
Yes, please. I can see a sorry. I don't know what is with my computer.
Yeah, hello. So in parts, Uta already stole my comment. So I wanted to point out that we radiation oncologists would have really loved to have more preoperative radiotherapy in the new trial, and we discussed it on several meetings. But we really felt also that we need to allow histopathological examination of the specimen for treatment response on chemotherapy, and that of course we would destroy, but we really would love to do it, and we still hope for our chance. And I think it's really also a chance for patients because the dose is lower and the volume is smaller. So yeah, but we need to take into account all needs, and so therefore we decided to not go with more preoperative radiotherapy.
Perhaps a comment from my side then. If we consider what we discussed today in this session, I absolutely agree with you. She knows that I believe that the role of histological response is very, very important still in the treatment of patients. However, I find myself asking myself now whether in some cases, like the one Andreas just showed, and considering what Arnold showed about the necessity of not waiting too long until local treatment, considering the impact of treatment delays, whether in these very special cases, the thing that Daniela showed us with doing first radiotherapy, completing then the systemic treatment so we don't have delays, and then perhaps do surgery at the end might not also be a good option for very selected patients. so that we don't have the delays, but we also do the treatment of the patients as intensive as possible.
I think Lian also raised her hand, and then Michi had enough time to take pictures of us all. And remember to smile all the time.
Okay. I had only one addition, Uta. Maybe because we know the new results, and I think most of the countries are not doing Bumel after a poor response in patients with a RIP Ewing sarcoma or a Ewing sarcoma of the thoracic wall, and maybe that's a possibility to do in a near future a randomized control study for only a subgroup of patients. Yeah. And therefore the histological response is not so important as for the other groups. So
yeah, right, for thoracics I strongly agree, and I also wrote some comment. It's only a few patients, so it would need to be a real global study.
Yeah, I agree.
Okay, we plan from next year on.
Great.
Okay. I would also like to add one comment to the preoperative radiotherapy. So we have a similar discussion currently ongoing for the soft tissue sarcomas. And one major point is also to what extent we can internationally agree on such an approach, because we have a wide variety of expertise and centers all over many European countries. And we know that for preoperative radiotherapy, the ability to do surgery is very much also depending on expertise. And I think it's always difficult in a multi-institutional trial to be on the same line in such an approach. So I think it would be interesting to know from the surgeons if they would all agree, in case we would ever have such a question, if we could even agree on this procedure for a cohort of patients, and would all be willing and able to do it.
I think we need a completely additional session on this, and I think we would just dedicate a session to this maybe on the next meeting, or maybe on the SIOP Europe meeting. We will see. And thanks so much for all speakers, and especially thanks to Arnold, who really got up in the middle of the night to share the US data with us. Extremely highly appreciated, and have a wonderful and very long Saturday. Okay, I think we have a break now.